Have you ever wanted to work in a flying ICU? Or maybe you're just passionate about saving lives. Right now you can realize your dream by applying to work for one of the best teams in the air medical industry. Air Methods is currently hiring qualified flight nurses, medics, and mechanics to join our air medical team. Check out our new salary and benefits packages. Visit airmethods.com/careers and apply today. That's airmethods.com/careers.
The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and Flight Bridge Ed in their entirety. This is the Flight Bridge Ed podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric back with you. Today's podcast is something that I've wanted to do for some time. I'm joined with Joe Hylton from Hamilton Medical, and super excited to be able to do this podcast with him. I'll let him introduce himself, and then we'll dive into the topic. How you doing, buddy?
Doing okay. How about you?
I'm good. Hey, for the listeners out there, really quickly go through kind of your background, and then we'll dive into this topic that we have talked about doing for about 6 months now.
Sure. So again, named Joe Hylton, in North Carolina. I'm going to date myself when I give this kind of background, I guess. It's a good way of saying I'm old. I was an EMT in high school back in the late 80s. Then went to RT school. After that, worked at a couple of large trauma centers in North Carolina and decided to pick up a paramedic cert while doing that and started flying Life Flight in Charlotte in 2008. And did that full time until 2016, and then went to work with the Hamilton in clinical applications. And that's kind of where we are now. I still do the Hamilton stuff full time. I do pick up some per diem shifts on the flight side and some per diem ECMO shifts at the trauma center as well. So, in a nutshell, that's my craziness.
Well, great. Well, you have been a great resource, great friend to us at Flight Bridge Ed, and you've always been willing to give your time. Anytime I have a question, I have something that I need to bounce off you, you're always very gracious with your time. You answer my calls. And so I've always been very appreciative of that. So thank you. And I think that's what leads us to this podcast. We had a great conversation at AMTC, and I often share these experiences where I feel like in a lot of cases I'm called on to answer questions. I'm emailed different scenarios, different things like that, but I don't always have the answers, and it's all right. It's all right to not always have the answers, and I think that I always find that when we talk, you always teach me something, and I really appreciate that. And I think I said that to you at AMPC that sometimes you kind of blow my mind with the way you explain something, or you go about it a different way. And I think that's just a reminder that we are all teachable. We always have to continue to want to learn. And again, that's what really stimulated this podcast was some of the things that you had said, and then ironically, I ended up getting different questions in different vent courses or emails that were along these same lines. So that's where we come to today, is talking about specifically the Hamilton and how a breath is delivered, and really the two methods that a breath can be delivered from the standpoint of really foundational. Volume adaptive versus true pressure controlled biphasic. And where I really believe you can shed a lot of light on this is, I really feel like this is the number one ventilator in the industry. You're seeing this become the standard across so many different platforms. And when we teach mechanical ventilation courses, we are seeing a lot of companies that have purchased Hamiltons that want a little bit more in depth. But I'm seeing consistently a lot of crew members want to default to a specific thing because it's easy. And so that's where I really want us to talk about why we might approach a patient from volume adaptive, why we might approach a patient from pressure controlled biphasic, what is the difference between ASV and these two ways of delivering a breath? And why would we go one versus the other? And so that's where you come in, is really highlighting the differences and bring your expertise to the table.
Sure, absolutely. And you're very much correct about us all being teachable. Someone took the time to do it, to show it to me. And of course, doing things and finding out things that didn't work. You remember, don't do that again.
Yeah.
We've all been there and we've all grown from it. And it's our job, it's our duty almost to help other people out when they have those issues. So you're very on spot on that. It's a village, and we got to help each other because we're all trying to do the same thing.
Well, yeah, and I think you have to, as we both get older, right? This is my 31st year in EMS in some way, right? Starting as a volunteer firefighter at 17, and not sure if you've got more years on me, probably.
It's close.
Or right there, right? But I think as you get older, you realize, and we become less about ego. At least I found myself to be that way, and it's all right to be wrong. It's all right to learn new things, and I think that's great. I wish I had the same mindset maybe when I was younger, right? And I think many of us probably reflect on some of the things that we may have thought, or the impressions that we maybe gave to others, and so I love these conversations, and I think that's what I want to get out when we talked in the pre-show at the FlyBird level, right? The podcast, whether it's education being delivered in different realms, we've always tried to break it down very simplistically to where it's immediately applicable to a clinical setting. And we want you to be able to come out of this podcast to be able to make better clinical decisions. That's the key. And so we're going to use some examples and go through maybe some patient subtypes of, maybe we go one way or the other. So, Joe, where do you want to start off? Obviously, we have a simulator here, and you've been gracious to show it from this perspective. I guess let's start off. What types of patients specifically would maybe you get called to the bedside where you would go pressure control biphasic over another method, or vice versa? What types of patients would you maybe start in a different way?
Okay, speaking solely with the T1 and not other devices, there's a couple things to remember. The T1 by design is a pressure ventilator. So any breath that it delivers is going to be a constant square pressure waveform, and you'll have a decelerating flow waveform like walking down an escalator. So that is, by definition, when you look at mechanical ventilation, that is a pressure-controlled breath delivery. So no matter the mode on the T1, everything except high flow O2, it is using that pressure and flow pattern to deliver its breath. So from a pressure control standpoint, and this is a very good way to dive into it, the things to remember, if you go back to mechanical ventilation 101, minus your adaptive control modes, you have a volume targeted breath or a pressure targeted breath. Whatever your target is, you have a variable. So if you're targeting volume, pressure becomes your variable. If you're targeting pressure, volume becomes your variable. And those variables are going to be based on the patient's lung mechanics, compliance and resistance, and their work of breathing that they exhibit. So all three of those are going to come into play when you look at the variable piece. So in pressure control, it's very easy. The mode is telling you pressure control. We are going to tell the machine every breath what pressure to deliver. So that's going to be a safety piece there. The variable becomes, what does your tidal volume, what does your minute volume now look like? Is it consistent? Is it not? Based on the mechanics and the work the patient delivers. But the good thing about it, no matter what, from a patient effort standpoint, they see the same level of pressure every breath. So they'll see pressure is consistent and flows are going to be more consistently delivered across the board. Of course, you can have variances with that, but that's going to be your best way to look at it. So someone on the T1 that may be breathing spontaneously quite a bit. Someone that we maybe can't sedate because of hypotension, we haven't got their volume status, or they're squeezed on their vasculature to a point where we can start to give some benzos or narcotics. Pressure control may be a good place to start from a consistency standpoint. We can look at our waveform, see if the patients are getting the flow they need. We can adjust pressure up, or in some cases maybe down if we need to. We can make sure that we're hitting the volume target and or the patients getting the inspiratory flow that they need to meet their current demands that they get. And waveforms are another class altogether. We're not going to dive into that and get crazy today with it, but that's some of the things that you can look for when you're looking to do a pressure breath. And remember, when you talk pressure, you have pressure control, where you're going to be given a rate. From that patient aspect, you also have the spontaneous mode, which is going to be CPAP plus pressure support. So you have the spontaneous breathing angle too. If there's maybe a timing angle from your patient, they're really tachypnic. Or maybe you have a patient that they're doing having neurostorms of some type. And again, we're trying to get rid of that. We get 3 H's, the hypotension piece. We're getting access. We're giving blood volume. We're giving other kinds of volume to get pressure up to be able to get a grasp on that crazy breathing we're seeing. Sometimes spontaneous may work if they have a good underlying drive, because then they have a better control over their inspiratory time. And it'll take some of that fighting or asynchrony away. So don't forget, when you have pressure, you've got the control piece and you have the spontaneous piece too, to kind of aid you in which you may select to get the patient a little more comfortable and a little more synchronous, because that also plays a big role in what we do on the transport side, especially if we can't adequately get a grasp on analgesia and sedation.
So let me just really quickly recap what you said, because I think you said some super powerful things. When you're giving a pressure breath, the variable is the tidal volume,
yes,
which is compliance-based, and the minute ventilation, right? And one of the disadvantages, if you would call it a disadvantage, is that in pressure control, you do not have a guaranteed minute ventilation.
Correct.
From the monitoring standpoint, and what I loved is you said when you're delivering a pressure-limited or triggered breath, you're monitoring the volume, right? And the volume that you're monitoring is the exhale tidal volume.
Exhale tidal volume and minute volume.
Correct. In a volume breath, a true volume breath, and so that's going to be other ventilators, the Ravel, the EMV Plus, right? Other ventilators that have a true volume breath. In contracts, you're not monitoring, right? You're setting a volume, but you're monitoring the pressure, the PIP and P-flat. Okay.
Correct.
And so that is really the difference in the compartmentalized manner, right? From a foundational standpoint, the differences between volume and pressure and what you're monitoring. And I think that's super important, because when you're teaching intro level mechanical ventilation, that is a very, very important piece to say, hey, if you're giving a pressure breath, you're monitoring volume. If you're giving a volume breath, you're monitoring pressure, right? And it's a great way to flip back and forth. All right.
Correct. And if you're doing volume control, absolutely, plateau pressure is the bigger one of the two to keep an eye on, because increases in airway resistance, secretion, small tube, for example, you can see a fairly high peak airway pressure, but your plateau may be an acceptable number to look at. So plateau is going to be the bigger one in a true VC mode to pay closer attention to. That's going to be what's causing the damage and causing the issues.
All right, absolutely. So you've got a patient, and you've highlighted why maybe you go with pressure. So there's some patients that maybe would benefit from, or there would be no problems with going volume adaptive. And what types of patients would those be?
Right, from a volume adaptive piece, and just to give a little insight into the volume adaptive, I'm going to pull the modes up on the T1 quickly. So if you look along the top where you see volume controlled or adaptive, you'll see APV or APV SIMV. Some machines may have the SCMV and SIMV plus. They're the same modes. You have the option within configuration on the T1 to name those differently, but they're doing the same thing. So please remember that. The top two tabs where it says volume control, they're always doing the same things. So some industry ugliness, and it's just a fact. PRVC was a mode that was presented to medicine probably in the early 2000s. And the company that invented that mode, they trademarked those 4 letters, PRVC. So any other company that at the time that wanted to have a mode that did the same thing, they had to name it something else. So enter in on some machines VC plus or volume guarantee or autoflow or APV. They're all doing the same thing.
Okay.
So it's kind of like when is PEEP CPAP and when is CPAP PEEP. They're both doing the same thing. They're
Love
doing
that
the same thing physiologically. Yeah. So I think that's an important part to remember. So if you come to a hospital and really PRVC is probably the most widely used mode across the U.S. now. If you see that or volume guarantee or autoflow, when you hit your modes tab, your top 2 tabs, you have a CMV or an SIMV option to select. That's going to be getting you on the equivalency page of PRVC. All right. And before I dive into that question, I would be remiss if I didn't just do a real quick demo to let folks see what PRVC or the adaptive volume control modes are going to do, because they do things very differently.
Okay.
Because the machine is now trying to manage 2 variables, not just one. So remember in our precursor, we mentioned you do a volume control breath or a pressure control breath. So you had a constant and a variable. And when you start doing these adaptive modes, you have now 2 variables that you have to pay attention to. So we'll quickly look at the CMV portion. I'm going to go into controls real quick. And when you look at this, you're setting up the same things you would an assist control volume. You're setting a idle body weight to targeted tidal volume, PEEP, FiO2, a rate and inspiratory time, which is going to give you your IDE ratio, the sensitivity or flow trigger. And in the Hamilton's case, you're physically setting your pressure limit. We'll talk about pressure limit in a second too. But the settings you put in, it's assist control volume. It's the same thing. And there's a lot of reason for that. Before I start my machine, this is going to be a normal physiology patient that you're going to see. Pay attention to what the machine does. We've told our ventilator we want to give a 430 ml tidal volume. Pay attention to exhaled volume. Pay attention to peak airway pressure. So your ventilator is going to give a series of 3 test breaths to look at mechanics. So if you're going to use a volume adaptive mode, it's a very good idea to connect to the ET tube first and then start your ventilator. Not the opposite. If you start your ventilator and your vent circuit is disconnected, then your machine is giving breaths and it's seeing a bunch of zeros come back. And then you connect to your patient after 5 or 7 or 8 seconds and your partner asks, hey, where did that liter plus tidal volume come from? And it's because we're playing Yellowstone with the vent circuit. We're not connected. We're playing cowboy or cowgirl. So connect first, then hook up. That way, when the machine starts, it's getting quantifiable lung mechanic data back to be able to act upon. Depending on the software version of your T1, if you had the older version, the 2.2.x, 2.2.10 and earlier, your machine, when you selected volume adaptive, it would give 3 test breaths, and the maximum pressure change that the machine could use is 2 millibar. So in this case, when we started our machine, we had told it, in this case, to deliver 430 mLs. We started our device. It started at a driving pressure of 15, and it saw an 800. And there's the machine's first clue. My starting pressure is too high because exhaled is way higher than what we were told to give. So the machine's going to incrementally now start dialing down the airway pressure to make exhaled match what we told it to deliver. So there's your two variables that the machine's working off of. You've got your volume you told it to give, and then you've got the pressure piece of it. So the old software, it would have taken it a lot longer to get to the target breath because it could only drop or increase pressure by a factor of 2. The newer software at 3.0 and up, this actually has the same adaptive mode inner workings that the G5 and the C6 ICU machine has, or what we call fast APV. So now that first breath, the second breath, now the machine can adjust pressure up or down by the first one by up to 8 millibar. So it can make a giant jump if it needs to. The benefit is you're going to get to breath target a lot faster. Faster. So you're going to minimize the time that you're going to see between what you have set and what you have delivered. And there's usually the examples that Hamilton has given from Bonaduce. There's about a 6 breath difference in old versus new software quicker. So you're more consistent in what you deliver. So in this example, you saw us set a volume of 430. The machine did its work. It saw the initial exhale volume be higher than what we had set, so it lowered airway pressure. So we're going to take our same patient. We're going to make them septic. We're going to give them the 30 or 40 mLs of volume. And before I make that change, I'm going to go to monitoring real quick.
Okay.
Like mechanics. So you can see your static compliance is 58, 59, 60. Our airway resistance, our RINS, is very low. So there's nothing happening from an ET tube, tracheostomy, conducting airway standpoint. So we're good here. Your RCEXP calculation, respiratory time constant, 0.6 to 0.9 is a normal range for that. So we're on the lower edge of normal there. But I want you to pay attention to these numbers. Resistance is good. Compliance is good. Our RCEXP will take. Now I'm going to make your patient sick. So this will be your typical sepsis patient that's got a lot of volume. Right. Airway resistance is the same. Your lung compliance is now 20. Look at your exhale tidal volume now compared to what you have set. Mm-hmm. Now your exhaled is lower than target. And watch your peak airway pressure. Now your machine is adding pressure to try to make exhaled volume match what we set our target to be. So we've gotten 2 good examples now of the machine taking airway pressure away. Now we're going the opposite way and letting you see that it's adding airway pressure. You think that's a good contrast of what the mode is trying to do from a basic standpoint?
Yeah, can you really quickly touch on how that peak airway pressure at 30 is impacted by your pressure alarm?
Sure. That's the next thing I was going to talk about. Good question. So, a couple things to look at from a visual standpoint. If you look at your pressure waveform, you see a blue line and you see a red line. So this is giving you a visual of your high pressure alarm, red, and your pressure limit, which is blue. On your Hamilton device, there is always a gradient of 10 between alarm and limit. So to let you see that numerically, I'm going to hit alarms. Notice your high pressure alarm is 40. I'm going to press controls. Your pressure limit is 30. So you see the difference of 10. If I make my alarm limit 40, under controls, and now I go to alarms, you can see your alarm is now 50. So there's always a gradient of 10 between alarm and limit.
So it sets the gradient for you.
The gradient is ingrained. You cannot get rid of it.
Yes.
So if you change the limit, the gradient always moves by a factor of 10. If you change the alarm, I'm going to put the alarm back down to 40. The limit is going to also, again, go back to 30 where we had it. There was always a factor of 10. The difference in the alarm and the difference in the limit. The high pressure limit, this is the governor on your ambulance. So when you're trucking down the interstate and you hit 70 miles an hour and you hit your governor limit, your truck doesn't stop, but it doesn't go over 70. So to bring that analogy to the ventilator, if your pressure, inspiratory pressure, peak airway pressure hits the limit, it doesn't stop the inspiratory time. It just blows off that excess pressure, kind of like a pressure pop-off valve on your pediatric or neonatal BVM. Doesn't stop the breath. It just kicks that excess pressure away. Clinically, what you're going to see, and let me just show you. I want to make this tidal volume high on purpose, and it's going to generate an alarm for us. So there is your alarm, pressure limitation. Your ventilator's telling you, hey, Joe, I can't deliver exhaled the tidal volume that you told me to deliver because I have hit the pressure limit. So that's what you're going to see clinically. An alarm telling you that the waveform has impacted that blue line, and you're going to see exhaled be lower than what is set. So if you ignore this alarm, then your patient's going to be hypoventilated. They're not going to be getting the volume that they need. So that's an example of what the limit will do. The high pressure alarm, that's the kill switch for the breath. So if the patient coughs, and I'll give you an example of that. So you can see that waveform impacted the red line. That breath immediately ended, and the ventilator dropped down to your PEEP level. So that's the difference in limit and alarm. Limit's a soft stop or an umbrella. The alarm, the red one, that one's a hard stop.
All right.
Now clinically, how those apply to you. 30 was not a random number that was picked. What's your maximum safe plateau pressure? 30 centimeters of water. So that's why your machine defaults to that. You'll always be at a limit of 30 and an alarm of 40 when your T1 starts up on the adult PEEP side.
Can you expand on that? Because that is, I mean, that's a variable, I believe, of the Hamilton because, correct me if I'm wrong, because of it always being a pressure breath, right? That you can't do an inspiratory hold. You can't truly check a plateau pressure. And if we were to do that, we will always keep that plateau at 30. Is that the thought process?
So your T1 doesn't have an inspiratory valve. It does have an expiratory valve, but not an inspiratory valve. So just quickly, on machines that do allow inspiratory holds, those machines have an inspiratory valve and an expiratory valve. So clinically, when you do an inspiratory hold, your ventilator is going to do that hold at the end of your inspiratory time. Mm-hmm. What the ventilator does is when that hold begins, it closes the expiratory valve and it closes the inspiratory valve. So for that small amount of time, your patient is actually isolated from the ventilator. No flow is occurring. So in that second and a half, we do that hold, the patient's lung actually recoils against that closed system because both valves are closed, and we get a better reflection of true static compliance. So that's giving an example from a pressure standpoint, a plateau pressure standpoint, kind of globally where our lungs are in the condition of what we're doing with that patient. So that's what your ventilator does. Since your T1 doesn't have an inspiratory valve, it can't do a hold. So your T1 does calculate a plateau. It does it in a different manner. It's using linear regression to do that mathematics. Specifically, it's looking at the flow volume loop. And in the last 100 milliseconds of an inspiratory time, if it sees flow reach zero on that flow volume loop, then it's going to perform your plateau pressure calculation. On the T1, it's going to be exhaled tidal volume divided by static compliance. That equals driving pressure. Driving pressure plus PEEP equals plateau. So the machine will do that math to do that. If flow does not reach 0 in that time frame, you will see 3 dashes. Let's see if it's doing it for us here. You'll see 3 dashes under plateau. So you'll know that flow is not getting to 0 in that last little time frame of the breath to be able to get that. On the older software devices, that's where we'd have folks do the calculation. Exhale tidal volume divided by static compliance gives you driving pressure. Driving pressure plus PEEP equals plateau. On the newer 3.0 and higher software, something that's added to the calculations is delta P, or driving pressure, and this is almost always displayed. So this is half of that equation for you. Exhale tidal volume divided by static compliance equals this number. Delta 25 plus PEEP equals plat. So this has made the mathematics a lot simpler. This plus your PEEP equals your plateau pressure. So the new software has made it a lot easier to get to that endpoint for plats. I saw your eyes.
So you're saying that based on that, plateau pressure is calculating out at 30.
Yes, you got it. 25 a delta plus 5. And I've done this math. I've done the long way, looking at calculating a plateau and comparing this to, and it's very close. It is very, very close. I would use it all day from a validation standpoint.
Okay, well, and I think that is another topic that we definitely can dive into, and maybe if we have time, we'll dive into that, because I have my thoughts on that. I think I try to keep things simple, and I guess my mindset is if my PIP is below that threshold of kind of that safety 30, I know my plateau is lower than that, right? So I guess you could also look at that from a true ARDS patient where your driving pressure is your target. Maybe that's where you would calculate it. Is that correct?
True. Driving pressure is, if we're solely talking about plateau pressure, yes, 30 and under is okay. But now, since you brought driving pressure up, and this is something that actually came from the 2000 ARDSNet study.
Okay.
We definitely learned from that plateaus under 30, you had a less chance of dying from ARDS. Amato and that group looked at the ARDSNet data, and they were able to tease out that of everyone that had a plateau under 30, when you looked at driving pressure, 15 became a MAC number. So it's very possible that you could have a plateau at 28, 29, 30, but your driving pressure could be higher than 15, and they found that subset of patients had a higher chance of dying than if your driving pressure was less than 15. So if you're solely looking at plat, absolutely 30 and under. But if we're going to be really, really, really deep diving and getting in, we should look at plat and driving pressure as well, and see if they're both within range. And externally, 15 is the magic number for driving pressure you want it to be, 15 or less.
All right. So how could this patient right here be impacted, maybe from where maybe this method of delivery is not beneficial, or not the best?
I think we've got a good working of how the mode is operating now. I'm going to get this volume back down to where we had it to get rid of our alarm.
Okay.
Because we all like quiet machines, right? So, from an application standpoint, a moderately to heavily sedated patient, a chemically paralyzed sedated patient, your volume adaptive modes are going to work wonderfully. Okay? When you apply the volume adaptive modes from a clinician standpoint, one of the biggest things we need to look at is how is spontaneous breathing going to impact how this mode reacts to what the patient is doing. So taking what we've shown you earlier, we've given the machine a target tidal volume, and we've watched the machine based on what is exhaled, add, or take pressure and flow away. Hopefully some lights are starting to come on now. And the best one I love to talk about that we hate to see clinically is the intubated DKA patient. because most of them could have avoided it. But it's a good one to teach this mode with. So let's say for whatever reason, Team X decided this DKA patient needed to be intubated. They did that. As soon as they intubated them, they woke them back up. Thank God. So now the patient's brain is still trying to control things far better than we're probably ever going to from a timing standpoint and from a volume standpoint too. But now you have this Q-small pattern, this very deep, very fast breathing pattern. Okay. And we decide to use our volume adaptive mode. And currently our tidal volume, we have it defaulted to 6 per kilo. But even if we did 8 per kilo, so we're starting to stretch, kind of the higher end of our new normal. So 570, not that big of a volume, especially if you're looking at DKA. So we do volume adaptive. We put in 8 per kilo, and your patient is trekking away. They're consistently exhaling 7, 8, 900 ml tidal volumes. We're not going to set our vent that high.
Right.
Because we're not going to put our vent at a 15, 16, 17 per kilo tidal volume. But how this adaptive mode is going to act. Let's say your patient's consistently exhaling 800. And your target tidal volume is 430. So the mode sees these exhale volumes being high, looks at what's set, and the vent decides, you don't really need my help. I'm just going to take all my stuff and I'm going to go over here and sit in the corner. And when you tire out, then
I'll be here.
Yeah. Clinically, you're going to see peak airway pressure start to drop.
Okay.
And in this scenario, the peak airway pressure, the machine can turn that peak airway pressure down to as low as 5 above PEEP. So imagine someone with a flow demand that high. And in response to that, we as clinicians turn their pressure and flow down and take it away from them. So that's what the volume adaptive mode is going to do.
And that equals, if we drop the pressure,
yep, that's going to equal
the volume.
The volume is going to drop, the flow is going to drop, and your patient's going to look awful. They're going to look air hungry as can be. The old axiom, the funny thing we say, man, their sternum's banging their spine every breath they take. They're pulling so hard. That's what you're going to see. And then Eric and I are going to be going, hey, man, this patient looks awful.
Yeah.
And then we're both going to say, yeah, and we're probably doing it too with this right here. So that's a good example of when a volume adaptive mode might not be the best thing to apply. If you've got a high flow demand, that high Q-small type pattern, probably a good idea to, if you can't sedate or paralyze sedate, move to your pressure side, your per pressure target, pressure control or spontaneous piece. So that way the machine's not going to be taking pressure and flow away and maybe contributing to the air hunger and flow hunger your patient sees, which is going to jack up their O2 demand and increase their CO2 production and make the whole picture a lot worse.
Yeah, and that gets into a completely other realm. Obviously, these patients are already going to have a low pH, and any alterations to that CO2 is going to cause the pH most likely to drop because you're going to
correct.
The CO2 is going to rise, and then if it's already critically low, then we might not have a patient at all.
Correct.
Correct. No, and I think that is a great example. Here's the thing that I want to kind of stop and pause. The thing that I've seen anecdotally teaching these vent courses, and I don't know, I can't really pinpoint why. And if you're listening, and you're going to have to ascertain this yourself, it might be a comfort thing. I think the language on the Hamilton, when they see volume, they truly, I have to make this statement or explain this on every course, that this is not a volume breath, that this is PRVC in a nutshell.
Correct.
And a lot of times you see kind of those aha moments, like they had no clue. And I don't think it's anything that's represented wrong. I think it's literally the clinician reading volume and thinking they're using a volume breath. I think people like to actually set a volume. They like to be able to turn that volume to what they want, and it gives them security.
Right.
Right. And I think the thing that we have to understand is That's all fine and dandy. But you got to understand what you're doing. You got to understand that that should not be the absolute default on every patient. And that's what I'm seeing, is that we have to stop and evaluate what patient you have in front of you.
Agreed.
And how do we move forward?
And that adaptive word.
Yeah.
One word means everything, especially in this case.
Yeah. What other types of patients would you say? I mean, you use the DKA patient, and I think that encompasses the high flow demand, the high metabolic man. Are there other patients that you would maybe evaluate and be cautious and go a different direction?
Absolutely. One that we unfortunately see a ton of. I'm sure everyone that's on that watches this podcast or watches this recording, they're going to go, yep, we sure have. It's going to be TBI.
Okay.
So, again, if this is a TBI patient that we've got really good control of, we've got the 3 H's controlled, the hypoxia, the hypercarbia, the hypotension piece all under control, then that patient can be adequately sedated, paralyzed if we need to, and we can get a good grasp on their ventilation. If it's in that resuscitation phase, though, and they're hypotensive and they're just at a point where we can't really sedate, we can't paralyze and sedate, and their breathing pattern is all over the place. So a neurostorm, chain Stokes, a BOX type pattern, those are all going to be, in result, the same when you look at this volume adaptive mode. So again, we've told the machine we want to give 6 per kilo. And we attach this to someone, and we'll use chain Stokes because it's the easiest one to teach. They're exhibiting that pattern. So you start the machine, your patient's in the normal phase of chain Stokes. Your ventilator's kind of settling out on which pressure to use. And now your patient starts to go into this waxing or large tidal volume phase of chain Stokes. So now they're breathing 500, 580, 700, 900, maybe even a liter tidal volume on this big phase. And now your volume adaptive mode's going, uh-oh. These volumes exhaled, they're way higher than what Eric told me to deliver. So, man, I got to get rid of some pressure. And it starts dumping airway pressure. So, again, you've got someone clinically at the end of the machine that's, based on their physiology they're begging for more flow and a bigger volume, and the machine is taking it away.
Yeah,
and you've
very similar to what you just said.
And you've increased O2 demand, and CO2 production's gone up in that case. So your machine responds to that. So your machine's always at least a breath behind. So the machine starts to lower airway pressure to make exhale match what we have set, and your machine's starting to get fairly close to where it needs to be with that, and then your patient now comes out of that waxing or large tidal volume phase, and now they're coming back down. Now they're 900, 700, 500, 400.
Yeah.
And now your exhale tidal volumes are 200. And now the vent goes, wait a minute. Now, since I turned airway pressure down, now I'm delivering less exhaled than what Eric told me to deliver. Now I got to go and turn this airway pressure back up again. And it starts to do that. And then your patient goes apneic. And then this whole cycle starts over again. Of the big volumes, then the low volumes, and the apnea phase. So in essence, the way I try to teach this is imagine my German Shepherd chasing its tail, and it never catches it.
Yeah.
So clinically on this TBI patient, we've hammered, especially in the last 6, 7, 8 years, that, stay on top of the 3 H's. Because ultimately, if we don't, secondary injury is going to suffer, and then your patient's going to suffer. And in this case, if your tidal volumes and your minute volumes are peaking and troughing, then you've got CO2 peaking and troughing as well. So we're probably not doing the patient any favors if we're seeing this phenomenon by keeping him in a volume adaptive.
But Joe, couldn't you just paralyze these patients?
If they will let you hemodynamically. That is the magic word, and I know why you asked that, because we've all seen it. Don't just paralyze your patient without the ability to adequately sedate them. Do not. It is horrible. I'm not going to get into details, but I've had that done for a short amount of time to myself, and it's one of the worst feelings you'll ever have in your life. So if you're considering doing chemical paralysis, please, please, please stop and ask yourself, do we have the appropriate sedation on board? Can we? Eric's going to laugh when I say this. We've all done it. We've all gone to Hospital X and picked up a vented patient, and we asked them, what have they had for drugs? And they've had VEC. What have they been sedated with? Oh, they got VEC. Okay, as we're tearing the narcotic pack open and scrambling, we've all seen it. And it's a nightmare. So,
well, and I think that brings up so many other, and we could go so down a rabbit hole there. I think
yes,
it's super easy, and I know it's a little different if you're in a hospital, maybe in an ICU, or you're in the ER where maybe you have maybe a more quiet environment. You don't have as much going on. You have more help. I think it's probably easier to stay up on top of that. But if you have a super critical patient, it's just you and your partner, and you're trying to, let's say this is a multi-system trauma patient. You've got all these other things you're doing. Just arbitrarily saying, hey, we're going to you give long-acting paralysis. We have to be very, very careful. We're going to forget. I guarantee it. I have forgotten when we have transitioned from sucks to rock as our primary induction paralytic. I found myself doing podcasts about that and find myself the next day on the aircraft realizing, holy cow, it's been 10 minutes since we've taken off and I still haven't given anything. It's so easy to get into treating the patient if they have other life threats that you're dealing with, and you forget that. So I am very, very much a provider that tries to never give long-acting paralysis outside of now we've transitioned a lot of us from the sucks to the rock, right? And I truly believe that we can keep patients sedated well enough with the medications that we have at our disposal. Whether you go Versed fentanyl or you go ketamine, whatever you do. But, I think that is an important thing to really discuss.
Agree.
So we talked about TBI patients, Cheyne-Stokes respirations. We talked about DKA patients with Kussmaul, big deep breaths. Very, very similar in that both of those, when you get into the big deep breath phase, that's where you're going to see the ventilators stop and evaluate and say, hey, we probably don't need help at this point. And so they're very similar in that mindset. Are there other patients that you would, be cautious, or does it really fall into high flow demands, high metabolic demands, erratic respirations, those types of patients that really you would focus on?
And you summed it up nicely. The two examples we gave are the biggest ones that we see that apply the best. But as you mentioned, high flow demands, your volume adaptive mode is usually not going to respond very well to the patient's needs. Any kind of irregular breathing. We use TBI, for example, but it could be someone with some huge anion gap in their having metabolic acidosis because of that. That's making them breathe crazy. But it's the same thing that we're looking at. But ultimately, does the patient have a big flow demand? Is there something going on that's making their breathing very irregular or erratic and non-consistent? And if we can't sedate, paralyze, we need to change what we're doing. The last one, and luckily we see it very rarely, but I always joke that every time I talk about this, someone calls and says, yep, I saw this a week later. Thanks for bringing that up and jinxing us. Is it going to be some kind of chronic air leak that you see?
Okay.
Now, ET cuffs, chest tube leaks, usually we can pack those or repair the cuff or replace the tube and we're good. But tracheoesophageal fistulas, where you've got that anastomosis between the trachea and the esophagus, those can cause you fits if you're doing a volume adaptive mode as well, because you've got a leak that you can't fix. So ultimately, the machine's going to give her breath. All that volume is going to go out the leak, and it's not going to come back to the ventilator through the expiratory valve. and then your ventilator runs down that rabbit hole of, oh, no volume, I got to give more, I got to give more, I got to give more, I got to give more. And your patient in the end is probably not going to be consistently ventilated the way they should. And you're going to see airway pressures get really high. And in that case, again, usually for an air leak, pressure control is going to be your best remedy for that, because you're giving the machine very explicit instructions. You're setting a rate, you're setting an eye time, and it's at that point you got a dumb machine. I'm going to give a breath this every many seconds. I'm going to give it for this many seconds, and I'm going to stop, and I'm going to do it again. And then it becomes a lot more consistent in how it does things.
So, trying to think about how to ask this question. Would there be a patient subtype that you would automatically go volume adaptive as a benefit over pressure control?
That's probably more clinician driven.
Okay.
If that makes sense. And I guess where I'm going to there is for someone that's that's very comfortable with mechanical ventilation. Spontaneous breathing for me is the big thing that I look for, especially if we can't adequately sedate the patient or get a grasp of that to make it to where it not affects how the machine interacts so much. But for someone that's brand new, they're probably looking at, yep, we like giving consistent volume. If our volumes get too high, or our pressure start getting too high in response to that volume, then we're going to go to pressure. So,
yeah,
that's a tough question to ask.
No, it is, and I did that. I baited you a little bit there because I was looking for that response. I think for me, I try to make it simple, and I think the thing I learned so much in teaching all these courses, and I have learned over this last 12 years. You take little nuggets from all these clinicians. It is amazing the people you meet and their individual experiences, their expertise, maybe in a certain area, and you're able to take those little nuggets and kind of put them in your tool bag. But when I'm kind of asked to explain why, and I always try to think about how would I approach this, I honestly feel like it's probably safest, and correct me if I'm wrong for saying this, it's probably safer, especially if you're learning mechanical ventilation. If you're using the Hamilton, it's probably safer to go to the pressure biphasic in that way. And again, I use safe as a term, but I say that because to me from just the brass tacks, right? We're talking foundation. The simplest way to explain this is the difference is you're actually adjusting a pressure with your finger to target a targeted exhale tidal volume that you've already calculated based on your ideal body weight times 6 to 8 mils per kilo.
Agree.
And in contrast with volume adaptive, you're entering a tidal volume that the ventilator is then targeting and adjusting the pressure for you.
Correct.
And I think the thing that I really, really emphasize is you are able to, as a clinician, critically think to a much higher level. You can see variations. You can see those changes. I feel like I want to control the ventilator a little bit more. This is me personally. And I think a lot of times we see providers choose that, and I ask them, why did you choose that over pressure? Well, it's because I could set a tidal volume. It's a comfort.
It is.
It is, right? So, but I struggle because I think that really in the grand scheme of things, it's the ventilator is either adjusting the pressure for you or you're adjusting the pressure and pressure. That really is the big difference from just the foundational aspect.
Agree. And not to necessarily throw a monkey wrench into what you just said, because you are right. You're very correct in what you say. When you look back at the ARDSnet, the structure of it, they actually chose volume control because of the opposite of what you just said.
Okay,
So
explain.
they chose volume control because that way, from a ventilation standpoint, the patient's CO2 is not going to peak and trough.
Okay.
And then it's the clinician's job to pay attention to peak and plat and adjust tidal volume accordingly. Now, what you said, in the end, we're doing the same thing.
Right.
And I switched to pressure control on your screen for a reason. So I went to assist control pressure. You can see that now that the tidal volume's gone. But on this T1, to show you just how easy it can be, when you press monitoring, we'll look down here in the bottom right. If you set the auto body weight, the machine is doing the math for you.
Yeah.
So if you wanted to target 6 per kilo, leave the monitoring tab up, and come up here and spin your pressure control level up, and it's going to take it a couple of breaths to recalculate. You hate to use the dial of pressure or dial of volume piece, but
no, I think that's a great representation.
It's kind of what you're doing.
I love it.
And I say that more from the old Biratrol set type thing. You know what I'm talking about. You know exactly what I'm talking about. I don't want to say that. But it's the same thing. You're using your data at hand. The machine, and the good thing is here, the machine is doing the math for you and just making it easier. So you can see in the span of not even a minute here, we've gone from 4 to almost 6 cc's per kilo. And we haven't had to pull a calculator out.
Yeah. No, and I think that's a really great example of how simple it is. It just is a little bit more hands-on is all it is. But it does give you that ability to, I think, interact more with the monitor and the screens.
And the benefit is on transport, we're taking care of one patient. If you look at ours, and obviously you're looking at an ICU unit of 10 to 20 to 30 patients, so that may make a better case for VC as well. But for us, yeah, sure. I'm not. Yeah. One thing that I think COVID taught us, because of all the variables it threw at us and all the different phenotypes that you may have seen, and all the subtypes, no matter whether we're doing something pharmacological or from a ventilation standpoint, we need to start getting into the habit of tailoring care to the patient. Yes, there's checklist things that we can run down and make sure that we've done or considered. We may not necessarily need them. But when we're setting volumes, when we're setting PEEP, when we're selecting drips, tailor it to what that individual patient is presenting in front of you. And then move from there.
So does your decision-making change if you're using volume adaptive? Does it change based on going assist control versus SIMV? Will the same thing happen?
If I'm talking to a group inside the hospital, yes. Very few hospitals use SIMV, and I understand their logic behind it. And there is some physiologic studies that show from trying to get a patient off of a ventilator that SIMV might prolong that, because the brainstem actually sees varying levels of feedback from a pressure flow standpoint. And that's a lot of the reason why you saw SIMV go away inside the hospital from a weaning or liberation standpoint. That's why you saw AC, spontaneous, back and forth, and skipping that in between. For transport, we're not doing much weaning. And we're multitasking, as you mentioned before. Mm-hmm. So in my eyes, SIMV or spontaneous becomes something else that we have to get the patient more comfortable and maybe buy us a little time. So clinically, sure. If I'm transporting, if I do volume adaptive, I'm probably going to hit SIMV. Mm-hmm. If the patient wants to take a breath, they can. And I do have a little bit of lag time to catch up to that. If you're starting blood or trying to get a second line or a third line or doing something, titrating drip, your partner's busy, that does give you a little bit of buffer. Same thing for pressure SIMV. If your patient wants to breathe spontaneously, they can. And from a breath synchrony standpoint, that's going to be huge too, because we can spend an entire lecture talking about breath synchrony and the issues that it causes us on the transport side. Because that's most of, if the spontaneous breathing's there, that's what we're fighting. Right. Synchrony. Mm-hmm.
Well, and I think that that's maybe another completely different podcast. I think
Yeah.
you really see, and you see it more on the nurse side. And I understand that there's, I think that the longer I've done, the longer I've been in medicine in this realm, but I think I really have learned this in the last 10 years is that just because my perspective is this doesn't mean that a medication or a mode or a technique is better or the right way in a different setting, right? There are examples of medications that we use maybe or anesthesia uses in the OR that doesn't really translate to what we do, or
Agree.
vice versa. And I think assist control is always that it's always that elephant in the room. And you'll see from the nursing side that's all they see. They see assist control.
Yeah, it's all they've taught. It's all they've been known. Yeah,
and then you say,
correct.
you need to try SIMV, and you get the look of death, right? It's the nurse look of death.
We never did that.
Yeah. And no, all kidding aside, but it's just a different example. And I think every ventilator is a little different. Every ventilator has different technology. If you compare the LTV 1000 or the 1200 with the technology, with the flow trigger and how that flow trigger works, and then you flip that and you say, well, the EMV Plus from Zoll, it doesn't have a flow trigger. And then you have the Hamilton that has no pressure trigger, but has a really wide flow trigger, right? Mm-hmm. There are so many variables that come into play. And I think it comes back to understanding your environment and understanding, when you walk into an ER and you tell the RT, I had this patient on SIMV, they might look at you funny. I've definitely had that happen, right? And they go right and they put them on assist control. And I get that question all the time. Well, they're just going to switch it to what they want to switch it to. Well, no, but they might not understand your setting, right? And so I love talking to RTs that have transport experience, because then you truly get a very objective clinician. And that's what I'm hearing from you, is that you might handle a patient in a certain way in the hospital that you might not handle the same way in the transport side because of the limitations of maybe the equipment. And I don't say that as a negative. I just say that as our transport method, the vibration, right. There's so many variables that come into play. And I think that's the important thing, is we have to be fluid. We got to be flexible, right? It comes back to the podcast I did, 50 Shades of Gray or black or white. We can't be black or white. We got to be 50 Shades of Gray. We got to be able to be fluid. And we got to be able to be adaptable and understand that every patient has to be evaluated based on their merits. And we can't get in this tunnel vision mindset.
Completely agree.
Joe, one more question, and I think you really pointed this out when we discussed this in Tampa. I think that's where we're at, Tampa. There are some very close similarities, if I'm not mistaken, with ASV and volume adaptive. And can you really highlight on really a lot of the things that we just talked about really go the same way for ASV? Is that correct?
Sure. Really drive it in. So in a nutshell, just to kind of dive into your question you asked, ASV is an umbrella term. It stands for Adaptive Support Ventilation. It is proprietary to the Hamilton, of course. But ASV is using existing tools on the machine to do that umbrella approach. It's really not introducing some kind of new voodoo, I guess is a good way to put it, when you look at it. So we've kind of talked about today in our lecture assist control versus SIMV versus spontaneous. Here is your first little caveat into ASV. ASV will let the patient breathe or not breathe. It's always looking for absence or presence of spontaneous breathing. And it takes that piece and it integrates it into how it reacts. If your patient is not breathing at all, then ASVs are going to go, yep, we're going to do assist control. We're going to AC you all day. If you start taking some spontaneous breaths, ASV is going to look at you and say, okay, noted. Now we're going to move over to my SIMV portion.
Okay.
And we're going to roll it. Or you have the patient that's had a reaction to their ACE inhibitors and their tongue is oozing out of their mouth and they get intubated for airway protection, and now they're wide awake. And we chose to use ASV for that patient, and the machine sees that patient with a very strong drive to breathe. And ASV again goes, noted, and you're able to do all the work. So I'm going to slide it over to my spontaneous piece and let you go, buddy. So it can move all across that spectrum. It can do spontaneous, it can do SIMV, it can do assist control. It's all based on the spontaneous breathing piece. Now, Eric's next question, I can see it in his eyes. Well, how does it do that? How? Okay, so 2 modes that ASV uses to reach all of those goals. Your assist control and SIMV are, guess what? Volume adaptive.
Okay.
So if it's in the AC or SIMV phase, it's going to be giving or trying to deliver PRVC type breaths. The spontaneous piece, there is a spontaneous version of volume adaptive called volume support. And that is what it uses for the spontaneous breathing side. Volume support works exactly like volume adaptive or PRVC. So PRVC is a controlled, volume support is a spontaneous. So volume adaptive PRVC, your volume targeted pressure control. Volume support is volume targeted pressure support or spontaneous.
Okay.
So that's the 2 modes the machine uses to cover all of that entire spectrum of AC versus SIMV versus spontaneous. So now that you know that PRVC or the volume adaptive type breaths are being used for all of those contraindications are things we discussed about volume adaptive, the high flow demands, the erratic breathing, the air leaks we can't fix. If those are present, if you can't effectively sedate or paralyze and sedate, don't use ASV either, because you're going to get the same results because it's using those modes in the background to do its thing. Very, very good question. Very good question.
Yeah, I think there's definitely those parallels. So I think I just wanted you to point that out. I think that was a great explanation. I think this has been very insightful for me. I think it not only solidifies what I've been teaching. I think I always pick up new ways of explaining things. As always, guys, we're here to ask those tough questions and hopefully find those answers. And super fortunate and excited to be able to have you on here and be able to share your insight and your expertise. I think the thing that I really want to emphasize to all the listeners is just understand that, number one, you have to be self-aware. For a lot of you, mechanical ventilation is brand new. And whether we like it or not, you are now flying in a critical care role where you're given a ventilator, and that's definitely probably the area you're going to feel the most uncomfortable, right? And that's where I say like it or not. That's just the part of it. But it's your responsibility. The company has to obviously give you the education piece, but please understand that it's going to take a lot more than that. You have to be self-aware and understand how uncomfortable you are and stay curious. And it is something you have to be very, very proactive on in becoming more and more knowledgeable. You can't just think that you can show up to shift and never pull the vent out and never study and never read and then get these complex patients and make the right decisions. I think that is the number one key. And I'm always very careful in how I say things like that. But I mean, there's just no substitute. You have to have that self-awareness and that self-discipline to understand there's a huge, huge responsibility that you're given when you're handed this ventilator or any ventilator that you're working with. And it's not going to be easy, and there's going to be times that you want to cry and run to the corner, and I've had those experiences, and I think the thing that I'm wired in a way that I don't like feeling that way. Like I don't like feeling that way. I want to fix that. That is good. And probably for me, it's almost an unhealthy side. I have an unhealthy side. Like I will become so obsessive about something. And I'm not saying you have to be that, right? And I think Tyler is the same way. We want to learn something to the extent, but I think the key is, remember, it's a journey. It's going to take a long time to feel comfortable, and you might not ever feel comfortable, and that's all right to never feel comfortable. That makes you continue to seek things out and search things out. I think that's the most important thing.
Completely agree. You got to have that awareness. And just to add on to what you said, folks will see Tyler talk or Brian King talk or you or I talk, and they're like, how do you know all this stuff? And they have to remember, and it's not a knock. This is, on this talk today, you've got 60 years of experience of dealing with things. Yeah. And we've seen a lot of things evolve. We've been exposed to things that we know what to do. We've been exposed to things that we also know what not to do as well. If you're in this for the long haul and you really care, that awareness that things happen and it didn't go as planned, and you're like, why? And that's never going to happen to me again. And we're going to beef up and make sure that we're on top the next time. It can be, I guess, unhealthy in some ways, but it's also very healthy that we've recognized that, we've paused, we've QA'd it and debriefed it and found out where the holes are lying, and we're trying to plug those holes up. So if you look at it that way, then it's very healthy, because you're not only helping you. If we take avenues like this, or we teach, and you're going to help other people too, that they're going to see it, and then they're going to go, oh yeah. They see this clinic happen, and we remember Eric and Joe and Tyler and Brian or whomever talk about this. And now they're on top of it. So our pain becomes, their aha moment, and they get some benefit from it, serve the patients.
Yeah, no, perfectly said.
Yeah.
Well, guys, as always, thank you for listening. Thank you, Joe, for your time today. I know this is a long podcast, and hopefully this adds things to your tool bag. I'll put Joe's contact, if that's all right, your
sure,
Hamilton
absolutely.
contact in the show notes when we release this. And as always, if you have any questions, feel free to email me, eric.bauer@flightredead.com, and we'll talk to you soon.
This has been a production of the Flight Bridge Ed Podcast, leading the way in pre-hospital critical care and emergency medicine education.